Thank you, CRST, Dr. Vijay, Dr. Ashay, for this invitation. First of all, full disclosure, I have not used any of these molecules, which I'm going to discuss. So don't ask me too much. It was as much as learning for me. Just like there's an EXON 20 club, which I saw the previous presenter speak about. So an EXON 20 club, I think, is pretty exclusive, something to look forward to. So we'll quickly just cover the basics of EXON 20 EGFR mutation, along with what standard treatments you had and what new treatment options you have right now. So how common is it? TMH data is 20%. International data is 12% of all EGFR mutations. So it's not that rare. And what are the kind of patients who you can expect to have these kind of mutations? Most of them are going to be non-smokers. Most of them can have metastasis in the CNS or in the bone. Now, the outcome of these patients, if you see in the graph here, is quite inferior compared to the other EGFR exon 19 and exon 21 mutations which are there. So there's the 75 increased risk of death if you have this exon 20 insertion. And the 5-year survival is 8% versus 9% in comparison with the other EGFR mutations. So what were the standard treatments which were given in this specific mutation? So there is data which has shown that pemetrexed, this is all retrospective, but pemetrexed performed better than the other usual chemotherapy agents with a PFS of around 5.5 months and an overall survival of 28 months. This is quite high. I think it's probably because this is all retrospective. But what it concluded is that pemetrexed, if you want to choose a chemotherapy agent, you got to have pemetrexed in it. The second thing looked at addition of bevacizumab to chemotherapy. Here you can see in the first line treatment, the PFS was slightly better, but you can see the curves crossing. But if you used bevacizumab as second line, you could have a median PFS benefit of above 4 months. So PEM plus carbo plus bev could be even better. Then came the use of the third generation TKIs in this type of mutation. But as you can see in this side, only one patient had response with osimertinib. Rest of the patients did not have. So osimertinib does not work. And then came immune checkpoint inhibitors. And here also, because as you know, driver mutations, this is not going to work much. Immunotherapy had no improvement in the PFS or overall survival, so do not use immunotherapy. And this is the final real-world analysis of exon 20 insertion mutation. They concluded that platinum-based chemotherapy is the best. So, at the end of the day, combine pemetrexed and carboplatin. Probably you could add bevacizumab to get some, responses. Now, what are the novel treatments? And this is what is changing the treatment scenario right now. First, there came the usage of a drug, poziotinib, which was studied, which is an oral TKI studied as a phase 2 Zenith trial. And this showed a modest response rate of around 15%, but it had significant toxicities like diarrhea, rash, stomatitis, and the median PFS was almost same like before, 5.5 months. So the FDA has not approved this for complete usage. It's given a new drug application and, the drug can be used in certain populations, but it's not official. Now, what has been FDA approved? The first one is mobocertinib, which is an oral TKI given orally. And this was the trial, which was a phase 1 expanded to a phase 2 trial. And they looked at patients who had this exon 20 insertion mutation, who had received platinum, and in some patients who did not receive platinum as well. And looking at the response rate, it was around 28%. And the progression-free survival was 7.3 months and overall survival of 24 months. So this was slightly better than what was previously used. If you look at the safety profile, there are side effects. Almost 50% of the patients are going to have grade 3, that too serious side effects. Some patients had heart failure. Some patients had pneumonitis as well. These are rare complications. The most common side effects leading to discontinuation was nausea and diarrhea. And the drug also has a boxed warning for QTC prolongation. So you have to look at the ECG once in a while. This was another cohort of the same drug. And they looked the usage of these drugs in patients who had received a prior TKI, had response to a TKI, and then after that progressed. So these are pre-treated patients, not with chemo, but with another EGFR TKI. Here, the results were not as good as post-platinum, 20% response rate and disease control rate of 90%. But this is a population you could use this drug in as well. Now, these are newer phase 1 trials of newer molecules which are coming. All these are oral molecules. I'm not talking too much in detail. These are still running in phase 2 as well. Now, what is the second FDA-approved therapy? That is amivantamab. But this is given as an IV infusion. So it's not oral, it's an IV EGFR inhibitor. So it's a bispecific antibody against EGFR and MET, and it has a particular mechanism of action where it causes degradation of the receptor, as well as it has immune cell directing activity, which means it helps the immune cells target these tumor cells. And this was the Chrysalis trial, which looked at the effect of amivantamab in patients with exon 20 insertion mutations. And this dosage is a bit tricky, and it's given day 1, day 2, first week, day, and then after that 1 week later, then every 2 weeks. And this trial showed that there was a response rate of almost 40% in the patients, which is the highest, higher than mobocertinib. And the population included a lot of brain metastasis patients, almost 22% of those. If you look at the median PFS, that was 8.3 months, and the median overall survival was 22.8 months. So this also almost matched the survival of mobocertinib. What about the side effect profiles? So this is mostly EGFR related. You got rash, paronychia, stomatitis. You have hypoalbuminemia, peripheral edema, but the most important thing is infusion-related reaction. 94% of your patients are going to develop this when you give it the first time. After that, it's less likely. So it's something like rituximab, but much, much higher, 94%. Other than that, you have diarrhea and rash, which is one of the most common reasons for treatment interruption or treatment stoppage. This was another cohort where in the trial they give amivantamab along with chemotherapy, so EGFR plus chemo. And here it had decent responses, but again side effects are there, and most of the side effects are again infusion related, and the other side effects are related to the chemotherapy usage. The response rates, as you can see here in the waterfall plot, is decent. 80% of your patients, when you combine with chemo, are going to have some form of response. This is ongoing, which is the first line usage of this amivantamab along with chemotherapy in EGFR exon 20 insertions. This is ongoing, so this will give you the answer of whether using this drug upfront would make things better or give you better survival. So the final, towards the conclusion, we have 2 FDA-approved therapies for exon 20 insertion, unfortunately not freely available in India. One is amivantamab and mobocertinib. And to take home, the message would be, if the patient has no money, no compassionate access program, you can go ahead with chemotherapy, of which PEM plus carbo and probably adding bevacizumab might help. If it is available, mobocertinib or amivantamab can be used. If the patient has multiple comorbidities, mobocertinib is going to be more toxic. But the usage is simple because it's an oral therapy, it's an oral TKI. Main side effects, you have nausea, diarrhea, look out for cardiac failure with mobocertinib. With amivantamab, always remember 94% patients are going to have infusion reactions. Thank you.
Thank you, Dr. Arun.